Thank you everyone for joining us. We have a really exciting session today. First, we would like to acknowledge the Ramaytush Ohlone people who are the traditional custodians of the land that UCSF sits on. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place, the land that UCSF sits on, their home. We're proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we can look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. Land acknowledgement is not where things, that's not the end. It's only the start. We're committed to working with our partners, as we achieve our mutual educational and community improvement goals. So thank you for attending. It's my distinct pleasure to introduce Dr. Aric Prather, who's a professor of psychiatry and behavioral health and the interim director of the Center for Health and Community at the University of California, San Francisco. Dr. Prather first came to my attention a year and a half ago when I was listening to his New York Times best-selling book, The Sleep Prescription: 7 Days to Unlocking Your Best Rest. Post-peak COVID, just so many people were sharing and discussing that they were having major sleep disturbances, and I really wanted to go out and say, well, what's new? What do we know about sleep? And I started looking for books, and this series of this 7-day series that was on the New York Times best-selling list. I like, oh look, there's one about sleep. And so when I would go running early in the morning with my dog, I was listening to this book, and I was just really amazed at what Dr. Prather was relaying about the science. And one thing that really stood out for me was his view that sufficient sleep quality really is a vital social justice issue. And he started to describe, and I realized, I really want to know more about social determinants of health and sleep disparities across the population. So I thought it'd be really great to be able to get Dr. Prather to come to speak to us about this, because a large part of his work really does involve trying to understand the social processes and determinants that contribute to sleep disparities in the population. So welcome, Dr. Prather, and thank you so much for coming and speaking to us today.
Yeah, absolutely. Thank you for the introduction. And it's sometimes I'm like so excited about that book and how I've gotten to meet so many people, but it also kind of bums me out that we're at the same university and it took this kind of like off this unrelated part of my job to bring us together. But so happy to be here and so excited to talk to you guys today. So let me get my slides up there. Okay, so I am really excited to talk about this and to talk to you guys today, because it's something that I'm really passionate about, and it really started when I came to UCSF. I had come to UCSF through a postdoctoral fellowship funded by the Robert Wood Johnson Foundation, their Health and Society Scholars Program, and I had prior to that been doing a lot of laboratory-based work, and mostly in the context of stress and sleep and the immune system, but became really kind of disillusioned with some of the laboratory work that we were doing, and it wasn't kind of having much impact, it didn't seem. And so going through this postdoctoral fellowship that focused on population health and brought together folks from kind of various disciplines to tackle it was incredibly exciting to me, this kind of interdisciplinary, transdisciplinary work. And so it was through that I began to think more about kind of the upstream drivers of sleep and learning more about kind of the disparities that are kind of stark and persistent, and realizing that, we spend, a third of our lives sleeping. It's such a fundamental piece of our biology and linked to our well-being and longevity, but often it's disproportionately available to certain populations and not others. And so I became really interested in trying to unpack those and do that at various levels. So I'll kind of talk about in general, the kind of what we know, and then some of the research that we've done, trying to dig a little bit deeper, and then some opportunities for intervention that we've been thinking about. But I know that I had heard that, some of the folks that are involved in this network are doing some of this work. So I hope that there will be an opportunity for some discussion. So I'll try to leave some time at the end. And then also I'm always available by email or something like that. So just to get started, so I'm going to be talking about the social determinants of sleep. And I use this picture because it just, for me, this really helped kind of capture one of the things that we're thinking about. So this was during the pandemic. This was a homeless encampment, and kind of this is City Hall for people that don't know San Francisco. And so just this way in which people were, really highlights kind of the disadvantage and the challenges that we have, that individuals in our populations are just not afforded the opportunity for sleep, despite the fact that we know how fundamental it is to our well-being. So, let's start with some of the basics. So insufficient sleep, which is typically defined, say, by the American Academy of Sleep Medicine or the Sleep Research Society, as getting at least 7 hours of sleep to maintain optimal adult health for adults, and it goes from 18 to 65 for that recommendation. There's a lot of people that don't get it, right? And there's kind of wide variation across the population. So this is United States. This is data from the CDC. And so you can see here that, one, there is kind of stark variation at the county level across the US, but there are also hotspots, right? For people that do kind of survey data around the US, these patternings are not particularly surprising. Certainly there are higher percentages of insufficient sleep in certain parts of the country, like the South. But as I think the other thing that this tells us is that there really isn't many places in the US where within that section, there is less than, say, 20% of the population that is reporting getting insufficient amounts of sleep. And so if you take the total, it's about 35% of the US adults get kind of insufficient amounts of sleep. And that likely has some important consequences. So just thinking about the population as a whole, and we'll get to the disparities part, but insufficient amounts of sleep, not getting the sleep you need, puts people at risk for a whole host of things. So psychiatric illness, I think the one that comes up the most is in the context of depression. We know that individuals who are short sleepers or have insomnia are at increased risk for developing depressive episodes. When people have depression and they treat the insomnia symptom, or they treat the depression, if the sleep complaints persist, people are at substantially increased risk of having a reoccurrence of depression. And it's not just depression, certainly anxiety disorders. Sleep is kind of thought to be maybe a transdiagnostic process, and is often baked into a lot of the psychiatric diagnoses, because sleep is such a critical piece to it. But on the physical health side, probably the largest literature is on sleep and cardiovascular risk. We know that individuals who get insufficient amounts of sleep are at increased risk for hypertension, myocardial infarction, stroke, cardiovascular related mortality, all of those sorts of things. Insufficient amounts of sleep is associated with increased weight gain over time. And so, there's kind of good data to suggest that, when people are chronically sleep deprived, they tend to gain more weight. And some of this is due to the fact that, potentially they're awake longer. And so to maintain kind of metabolic homeostasis, they have to consume more calories. However, in like laboratory-based studies where we deprive people of sleep, we find that, there are changes to kind of appetite hormones, ghrelin, leptin, increased insulin resistance, but also a tendency and a drive towards more high caloric foods. So, when people don't have the sleep they need, often it changes reward processing pathways that lead people to kind of consume more calories than their body actually needs, despite this kind of fact that they're awake longer. Insufficient sleep is associated with susceptibility to infectious illness. I won't talk about it today, but like our lab does a lot of this, looking at how when people don't get the sleep they need, that their immune system is impaired, And if exposed to a virus, are more likely to get sick. We also have work, including in response to the COVID-19 vaccine, that when people don't sleep as well, they don't mount the same level of protection that the vaccine is to provide. And that can have obviously downstream risk to things like breakthrough infections or subsequent infection from other viruses other than COVID. And then probably the largest interest, in kind of biomedical science generally, but in sleep as well, is the link between is around neurodegenerative disease, and there is evidence to suggest that sleep may play a role in kind of accelerated development of neurodegenerative diseases like Parkinson's or Alzheimer's disease, and there's kind of lots of important animal and human work trying to understand the mechanisms by which that happens. And then in general, people that are kind of getting insufficient amount of sleep, they're at increased risk for premature mortality by like all different causes. And, there's some that might be related directly to sleep, but also, when people don't sleep well, like they don't exercise as much, they don't eat as well. I mean, there's lots of factors that kind of coalesce to put people at increased risk for disease. And so we have this map, and one of the things that maps onto it is you can see that there is this kind of similar patterning around heart disease. What I'm not showing is that a similar map we can also put up of, say, poverty within the US, and you'll see very similar patterns. And so it's pretty easy to begin to think like, okay, there's these kind of, at population level, this variation, these hotspots seem to map onto one another. Obviously, there's some questions about causality, and we try to get at some of that stuff experimentally. But it's clear that there is this kind of patterning that we see that's consistent across various kind of risk groups, risk factors. Okay, and we know from I'm sure you guys are all well aware that there are kind of stark health disparities around these disease outcomes. This is just an example of cardiovascular risk factors, but basically minority populations, Black, Hispanic, are often at increased risk for developing these outcomes, the very same outcomes that are associated with insufficient amounts of sleep, also are seen here. And so this is just an example, like, so, hypertension is one that really stands out, with non-Hispanic Blacks being significantly higher rates compared to non-Hispanic whites. But this patterning, these health disparities are stark, and they're kind of persistent. And there have been many groups trying to understand how do we, what are driving these. And one of the things that, because we know about these relationships between sleep and disease risk, it becomes very clear that like these very similar disparities in sleep seem to match on to these disparities in health. And I think when I think about it, it's around sleep opportunity, right? As you heard from Edwin in the beginning, that this idea that sleep is a social justice issue from my perspective, and that really was coined by Lauren Hale, who's in New York. But this idea that not everybody is afforded the same opportunity to sleep well, right? In many cases, sleep becomes a privilege instead of a right, and I think that's a problem, right? And that is really driven by kind of upstream factors that govern opportunity, but there are also kind of individual level factors that we can measure, and so I'll talk a little bit about that. But just to kind of show some data with respect to this these racial sleep inequities. This is just data from the National Health Interview Survey, at over 400,000 participants. And you can see here on the left that this is short sleep duration. Again, this like less than 7 hours per night. And you can see that Black Americans tend to have are much more likely to be in this short sleeping group. And it persists mostly across age cohorts. And so you can see that once people get to kind of non-working age, typically there isn't the same spread. But certainly for much of our working life, you see that Black Americans tend to be shorted on sleep, and much of that is opportunity, and we'll talk about kind of the many things that are associated with that. But just to kind of put just to clarify kind of all the different kind of well-documented disparities that we see, where typically minority populations, especially Black populations, are not getting the sleep they need. There are many. So we already kind of documented the short sleep duration, but I can also tell you that the data really support individuals reporting just poor sleep quality overall, measured by lots of different ways, primarily by kind of very well standardized questionnaires, but also kind of in the lab. So poor sleep efficiency. So this is kind of when people have the opportunity to sleep, how much of that time is sleep, right? So when we go to sleep, anybody here, certainly it takes a little bit of time to fall asleep, and then you wake up in the middle of the night and you're kind of awake for some minutes, and then you get back to sleep. And so of that opportunity, how efficient are you with that, where you kind of fill up that space with sleep? It turns out that minority populations don't do as well. I think notably, and I'll talk a little bit about this towards the end, there's also some data to support actually kind of at meta-analytic scale that Black populations tend to have less slow wave sleep compared to white counterparts. And this is really interesting because the slow wave sleep, so sleep is not just one thing, right? There's different stages of sleep that we cycle throughout the night, kind of from lightest to deepest. So that's N1, 2, and 3 of the non-REM sleep cycle. And then we have REM sleep, which is synonymous with dreaming. But the N3, that's the slow wave sleep that we pick up on the through polysomnography. And that aspect of sleep has been most closely associated with restoration, feeling well rested, but also kind of biologically in helping to, say, clear metabolites out of your brain, to help people recover from like exercise, and just feeling restored at the cellular level. And there do seem to be these kind of like fairly consistent differences that we don't quite understand, but I think there are some factors that are probably driving it. Sleep disordered breathing, probably one of the biggest challenges in sleep is getting people screened for things like obstructive sleep apnea, which is associated with increased risk for cardiovascular events and metabolic conditions, is more frequently seen in Black participants. Daytime sleepiness, and then beyond just kind of the sleep piece, kind of inadequate sleep opportunity. And some of this kind of travels along socioeconomic lines as well as racial lines, which obviously are very challenging to disentangle, at least in the US. But shift work, right, is more common, as well as underemployment, right? So the need to kind of engage in a gig economy, to have 2 part-time jobs, right? All of those things can impact an ability to get sufficient sleep, because there's the opportunity isn't there, right? You're trying to make ends meet, and that ultimately over time can have these downstream effects on one's health, excuse me. Okay. And so I just want to take a moment and, about kind of the historical origins of racial sleep disparities, mainly just kind of in that these are so long-standing. For people that are interested, I really recommend this book by Benjamin Reese, who does a lot of historical work and has been kind of focused for some time on kind of how sleep has changed over time and how that has driven some of these racial health disparities. And it's tracked back to kind of the Middle Passage and slavery, and the fact that slaves had to kind of sleep together on these ships, and at the same time white masters, white populations were kind of obviously setting up this hierarchy, and there was this push towards white individuals having bedrooms kind of away from others in kind of this confined space. And it is in doing so has continued and perpetuated these disparities around kind of opportunity for non-white individuals to kind of sleep in these spaces. And it's really interesting how sleep has changed over time. And like obviously in our evolution, we didn't always sleep by ourselves. We also often didn't sleep in places that were quiet and kind of completely dark and all these other things. But, there are these cultural changes that have perpetuated this hierarchy and kind of these structural racist policies that have continued to perpetuate these disparities with clear health implications. Um, and so, when we think about how these sleep health disparities exist, of course, we focus on the sleep of an individual, but it's obviously kind of housed within this socio-ecological model of kind of societal, social, and individual level factors. And so there's just, there's hundreds of different, frameworks or models to try to emphasize this. But I think in general, we have this idea that people are kind of like clustered within their neighborhood, within their county, within their state, all the other factors that kind of are complex and driving an individual sleep duration that ultimately can have these implications. And so, I think in tackling how we kind of how we break down some of these structures, it's really important to think about it at all these various levels, which I'm sure the Health Equity Network is already doing. And so how do these socioeconomic factors and structural racism shape sleep health? And I think there's like several different ways, and I'm just going to provide those and then think about some data that supports this. So these factors and the structures in place shape health out because they determine kind of where people sleep, when they get to sleep, if they can get to sleep at all, and then access to assessment and treatments if they can't, right? So, there are all these things that need to happen for people to sleep well, because honestly, sleep is not kind of the safest of behaviors, right? You really have to kind of let down your guard to allow something like sleep to happen, right? And so there are obviously environmental factors that can move that around or kind of change the calculus for an individual or a community about whether they should sleep versus kind of using metabolic resources for something else. So first, kind of where we sleep, the role of the environment. So, if you think about an individual, kind of the bedroom environment is where many of us spend our nights. And so, questions about, can you even keep your room dark, quiet, and cool? So recommendations in our sleep clinic, like first thing that we do is, make sure sleep hygiene is taken care of. Like we tend to sleep better in these types of environments, but does everybody get to do that? And so, if we think about the cool part, I actually think there's, this is where we do see, these factors that may be driving or, highlighting these sleep disparities. So air conditioning use is an example. So, this is, survey data of households that had access to any air conditioning in the Los Angeles, Long Beach metropolitan area. And there were kind of stark differences between kind of the total occupied percentage and if you broke it down by groups. So, 39 in total didn't have access, but, much higher among Black individuals and those that are below the poverty line. And it is one of these areas. I mean, we can talk about this and what air conditioning use might mean for climate change and those sorts of things. But it is one of these leverage points for improving sleep health in populations where there are these disparities, could be in providing some of these services that can just make the environment a better place to live. Questions about bedroom environment around crowding. This data is not as clear, but there's certain, there's absolutely greater density of people per household in kind of low SES and in some cases minority populations. And this can also be challenging for the sleeping environment, of course. And so that's another piece of it. The neighborhood environment, right? Like where people live. Questions about kind of variation in noise and light pollution within areas. And so, I don't have a map of that for the US, but we have looked at this in the context of different cities. And you can see that, if you live by a freeway or by an airport or in places that have limited green space, we absolutely see that that can impact individual sleep. And because of historical urban planning and redlining and other aspects, certain populations end up living in those areas, right? People that are low income individuals from minority populations. It drives. It is, an instance where people are trying to manage their sleep despite these environmental factors that are contributing to sleep loss. Heat, absolutely. Green space and tree canopy have been shown to be effective in helping people sleep better. But also, we maybe talk about this later, that some of these interventions that we think about kind of improving the built environment do have consequences to the very populations that we're trying to reduce the disparities in the form of gentrification. And so, kind of doing these things thoughtfully is important. I think I always put information about climate change and its effect on sleep, because this is probably, for many of us, one of the areas that, if we're not doing research in now, maybe should be, because it will be, one of the biggest areas and existential threats to our future. And we do know that it has impacts on sleep. So a colleague of mine, Kelton Miner, who is at Columbia, has done work looking at, millions of nights of data across many, many countries and tracking temperature change over time and its impact on sleep of populations. And so what we see is that, as the minimum nighttime temperature increases, we see a reduction in the ability for individuals to sleep. And we can think about this on the worldwide basis, but obviously also within the US or even within urban areas relative to rural, within regions. And so, there's this clear trend there. We also see the same sort of thing that, the change in short sleep over time, as this begins to the temperature tends to increase, we see more and more people starting to fall in that bin, particularly at the less than 5 hours, which we do know is kind of the worse off for them. But then it's not just all individuals, it's just not all countries where we see these stark changes. And so if you then break down these effects by kind of lower mid, upper mid, or high income countries, that it's really the lower income countries that are taking on the brunt of these changes on their sleep as the temperature rises. And while this is done at kind of a worldwide basis, you can imagine that you will see the same sort of things as temperature changes regionally, right? So, where they maybe don't have the same availability of income, or there are complexity factors that are also contributing to this with respect to these other environmental and social processes. So kind of this is the role of the environment. And then, beyond kind of noise and light pollution and heat, there's this safety question, right? Do you live in a place that's safe? And I always think about kind of when I first started doing this work, I mentioned this to Edwin in the beginning, that I used to work at Duke University Medical School. And I remember so vividly that I was meeting with a patient. So I'm a clinical psychologist, and I was doing my clinical internship, and I was working in a pain clinic. And so I was doing an evaluation for someone, but I had this interest in sleep. So I always asked about sleep and all those other sorts of things. And I was talking to this Black woman who lived in a community right outside of by the university. But for people that know Durham, there's a lot of variation within kind of a small region with respect to kind of safety and socioeconomic indicators. And in doing this evaluation, I had come to find that she was sleeping so terribly, and it was really because there had been like a shooting just down the block from her, and she had been staying up every single night to watch over her family. And that seemed like a reasonable thing to do. And it just really got me thinking about, gosh, obviously, like if these things are happening, sleep is such a kind of a dangerous proposition. Your vigilance system will kick in. And that is, in some ways reasonable, but also detrimental to someone's sleep. And so, in work and doing this, People have done stuff in the context of safety and track people's sleep and neighborhood factors. And, as you can kind of see in these kind of bolded ones, that there's a increase in short sleep duration among groups that are in places where they live in an unsafe neighborhood. Insomnia symptoms are higher when there's a noisy neighborhood, which isn't so surprising. And there are these associations. And so, this is where kind of the role of stress really seems to kick in. And when we think about stress, it's certainly a bidirectional relationship. We know that when people have stressful experiences, it can have a negative impact on their sleep. But in turn, when people aren't getting the sleep they need, it can absolutely change the way in which we respond to future stressors, right? So clinically, I always talk about it as, when people don't have the sleep they need, kind of little things feel like big things happening to us, right? And when people are stressed, it bleeds into our sleep, in part because we're kind of trying to, be on alert. We might be extra vigilant, and we can withstand kind of a limited amount of sleep when we need to. I mean, ask any parent of little kids. I mean, we can do this, but over time, we might get this kind of feed forward process, which can have downstream effects on health. And if we're, a group that gets more of these stressors, then the likelihood is that you will have more of these sleep problems and may drive these health problems more kind of rapidly or severely. And so we've tried to look at this in the context of discrimination as a stressor, right? If we try to understand at the individual level what might be contributing to this, because of living in the U.S. or wherever, that this is absolutely a factor. And so we know again that the racial sleep disparities exist, and discrimination is thought to be a contributor to poor sleep. But most of the work has been cross-sectional, and so we tried to do this in a longitudinal framework. And so this was work done by a former postdoc, Amy Gordon, who's now at the University of Michigan. And in this case, we had access to 220 Latinx students who were freshmen at at college, but they were all either kind of first generation college students and or kind of low income students coming into this kind of high resource school. And so there was an increased likelihood that these individuals would experience some discrimination. I won't go into it too deeply, only to say that we kind of measured discrimination in a kind of a general way using the everyday discrimination scale. But we also looked at kind of people's anticipated discrimination. And this is important in context of thinking about sleep, that in some cases, people can just have this race-based vigilance, kind of being on guard against, these future slights. And that in itself can actually kind of, right, if your vigilance signals are turned up, it can be hard to kind of let go and go to sleep. And then we measured sleep using kind of a very well-validated global measure called the Pittsburgh Sleep Quality Index. And we did this over the course of time, multiple times across the school year. And so we basically had this, structural equation model. I don't know how to do this, but you guys probably do. I was really thankful that Amy could. But where we were really interested in kind of the extent to which kind of race-based vigilance kind of impacted, someone's reports of discrimination and sleep. We controlled for these other factors that we thought were important, like neuroticism and psychological distress, but then followed over time to be able to test these bidirectional pathways of, like, does discrimination at one time period at the beginning of the school year predict someone's change in sleep over the course of the year? And then also to kind of be interested in this idea that, like, as people, if they have poor sleep in the beginning, does it also impact their changing in their experience of discrimination, just because we know how sleep and social processes are linked to one another? And what we found was indeed that kind of people who had kind of more race-based vigilance did report more discrimination and greater discrimination over time. But I think the important part is it definitely impacted people's change in their sleep over time. That people that experienced more discrimination during the school year did have a degradation of their sleep over that same period. We are still following up on these data to test whether that had any kind of academic impact on these individuals. We did also notice that there was kind of a small but statistically significant effect of sleep in change in discrimination, which, you know, did play a role in kind of the one of the projects that I'll mention a little bit later, though I see that we're kind of rapidly running out of time. So we then, you know, moved into the laboratory because we had this idea that, okay, discrimination kind of, you know, seems to be related to sleep longitudinally. What happens if we actually manipulate not discrimination per se, but kind of the experience of social rejection on sleep? And so in this case, we recruited 43 community volunteers, about half that were African American. You know, they're all healthy. And then we did this manipulation that was done at their homes. And so, you know, I'm really interested in kind of experimental work to look more causally at some of these pathways. And so we went into their homes, and 30 minutes before bed, we gave them a laptop, and told them the whole cover story was that they were part of a project where multiple people were doing this all at the same time. So it's like a classic social psychology project. And I did this with a social psychologist who's done lots of work in this space. And then on one night, it was a control night, and they just kind of watched a neutral video and then went to bed, right? So their sleep was measured by kind of a wrist-based device, kind of a souped-up Fitbit, you know, that gives us a behavioral assessment of someone's kind of sleep and wake and how fragmented their sleep is. And then we asked them how kind of to rate their quality of sleep last night. But then on the experimental night, they actually went through a rejection paradigm, where they were thought that they were in this thing with other participants, and they did a combination of cyberball and a speech task, which I'll talk about in a second. And then we again measured their sleep, and so we're able to compare like what happens on the neutral night compared to the rejection night. All of this, of course, was staged. In fact, our research coordinator was in his car, sitting outside the person's home, kind of like tapped into their computer and kind of controlling the whole thing. A lot of work went into it to just get this small study off the ground. But what did we? So here's Cyberwall. So people who are not familiar with this is a kind of very well validated task that brings on the experience of social rejection. And basically, participant 2 was the real participant. Participant 3 and 1 were you know, controlled by the coordinator in their car, but pretending to be the other participants. And so what happens is you start when you play this ball tossing game to each other, and then at one point the other participants kind of cut you out, right? They just keep playing with one another, and then you just have to watch for the remainder of the project, or the remainder of the task. And then our real participant was, you know, randomly, in quotes, given the task of having to give a speech while the other 2 participants provided feedback. And unfortunately, it was not positive feedback for this participant or for any of them, and induces the experience of rejection. So they start writing things in the chat like, I hope you aren't as nervous as you sound, try to impress us. And then just like in the cyberball task, they basically just start chatting with one another while the participant's speaking. So, you know, hey, number 3, how's it going over there? Not bad. Sure glad I didn't have to give the speech. Rough. And it's fascinating how effective these tasks are, how like what social creatures we are when we feel slighted. And so what did we find? First, we did find that social rejection disrupted sleep. Compared to the control night, people did sleep less on the rejection night. Their sleep was more fragmented. Interestingly, they didn't report having worse sleep, which is like a whole other, you know, interesting phenomenon with respect to kind of subjective experience. But what we found was driving it was that people took longer to go to bed and to fall asleep after rejection. So because it was in an uncontrolled setting, people just seemingly were more activated and just didn't go to bed, right? So they kind of procrastinated their bedtime, and so ultimately slept less. And so we see, you know, a really big effect on task to bed latency. And then some evidence that it was, you know, it took them longer to fall asleep, which is sleep onset latency. And then interestingly, it wasn't just everybody, it was people who were ruminators. So individuals where this got in their head, they had a tendency to do this, something bad happened to them. Those were the individuals where they ended up staying up much later. And so it gave us an idea of like, oh, well, what are some of the potential mechanisms through which this might happen for individuals? And then can we then use this information to help better understand racial discrimination? So we looked at rejection. We did get half African Americans. We did not we were underpowered to be able to test that effect. And so we saw some kind of, some evidence that suggested that maybe this was worse for Black participants, but we wanted to test it more formally. And so that actually brought us to an R01 that was funded by National Heart, Lung, and Blood Institute that came out of this workshop that NIMHD had put on to test this more formally. And so we did a similar thing, but in a more controlled setting. So we recruited, about 70 Black participants and 70 white participants. And we did the same sort of task. This time we had a better control task, which was like a non-evaluative speech. But and then we randomized people to either be rejected by someone from the same race or from another race. And so in some cases, we have Black participants being rejected by other Black participants, and then Black participants being rejected by white participants, and kind of all the different combinations. We were able to control people's sleep by keeping them in the sleep lab. So we did 2 nights of the sleep lab. We counterbalanced whether they got the control or the rejection night. And then we also measured kind of cardiovascular functioning across the night, because we're actually trying to understand to what extent does this experience map onto some of the cardiovascular changes that we think sleep disparities are driving. So it's an opportunity to begin to kind of more causally understand these pathways between the perception of discrimination and sleep and heart health. Just to get through the sample characteristics, as you can see here, we basically tried to match on the groups on gender and age, so no differences there. But there are these things that come up in trying to do this that we aren't able to match on SES or subjective SES. So we'll never be able to quite disentangle that with the sample size that we have. But interestingly, we did document kind of the well-known racial sleep disparities. And I think this is actually really important, and something I just want to take a minute to say is that, when we started this study, we were recruiting Black and white participants, and we had this very thorough eligibility screening, where to get into the study, no one could have any psychiatric conditions. You couldn't have any sleep disorders. You couldn't be taking any sleep medication. You couldn't be taking any other aids to help with your sleep. You couldn't be taking any medication that would impact your cardiovascular system. You couldn't be very overweight because of how it would affect some of the cardiovascular measures.
Highly selected.
What's that? Highly selected.
Highly selected. You're
highly. Oh yeah. So yeah, even beyond
that. non real world.
Right. So this is experimental setting, and then the other piece that, I mean, this is actually the thing that I wanted to mention, is we also had everyone screen in where they had to have stable, like they had to meet like a sufficient amount of sleep, right? And this is like done in almost all types of sleep studies, particularly clinical trials, where people have to have stable sleep. So they have to, like, on 5 out of 7 nights kind of be within this window when they go to bed and when they get up, and they have to have sufficient amount of sleep, so nobody can be short sleepers. And so I was terrified, when we were like near the end of the study, that I was like, we're going to remove every sleep disparity, because we were so strict about how we did this, but yet we still see the expected sleep disparities. So, I mean, in some ways, I'm like, wow, like these are really rampant sleep disparities. So one, we see like very, significant differences in kind of their global sleep score, right? So this questionnaire that I mentioned before, but we also see a trend in kind of wake after sleep onset, and we see this difference kind of in sleep architecture that's in the that has been seen before. So in this slow wave sleep, so despite all these other things that we controlled, we still see these disparities. With respect to the rejection task and the manipulation, we're actually still in the process of trying to figure that out. There's a lot of data that we're processing because the study just ended, but I do want to share a finding that's related to this slow wave sleep, and it's in the context of memory, because one of the areas that we're interested in is, could sleep and these sleep disparities contribute to some of the neurodegenerative disparities that we see. So, right, so Black Americans are at increased risk for neurodegenerative diseases, just like every other, of these types of age-related conditions. And so could sleep be playing a role there? So we were really interested in kind of adding on memory tasks to this project, to see if we could see some of those things. And so this was work done by my former postdoc Lauren Whitehurst, who's now at the University of Kentucky, where we did memory, performance, and coding twice before people went to sleep, and then a test in the morning, and to see how well they did. And we can kind of track. This was all done during the control night, so not on when they got this prior to the rejection, to see about the relationship between these sorts of things. And so it was a word pair association test, with pairing neutral and negative words, and then a retrieval of this to see how many they recalled correctly in the time. And what we found was, as I mentioned, there was this, so I mentioned there was this clear disparity in slow wave sleep, but we also saw that African Americans or Black participants did a poor job in responding to or doing on the memory task in the morning. And it was, mediated by this difference in slow wave sleep, potentially suggesting a pathway through which we may understand how sleep might be driving some of these things. And of course, this is just one memory task, and all of the participants in the study were already ensured to have kind of no, memory concerns or cognitive concerns, or, as measured through the mini mental state examination that we did prior. But it does kind of leave us thinking that even in the smaller sample, we might be able to understand how sleep, and specifically this aspect of sleep, might be contributing to some of these findings. Okay, so that's that. I just want to briefly talk about these opportunities for intervention. And so, we've, as I mentioned before, there are lots of places that we can do this. Ultimately, I think it's, at the policy level and kind of changes in which we kind of structure society to be more, to be less racist and more affording opportunity across the board, and be more equitable. But, when we come to sleep specifically, there are kind of some places that we seem to be kind of low-hanging fruit, like places where we can make these changes. So I just want to outline those real quickly so that we can have any time left for discussion. So I definitely see this as kind of multi-level intervention opportunities. On a societal scale, the one that's gotten the most traction has been around school start times, right? So, ensuring that middle school and high school start later. Obviously, this promotes challenges within communities, but, from a sleep perspective is probably the one where we might be able to make the biggest impact, at least for adolescents and young adults that then become adults and move on. And so, might be a great place to do this. Eliminating daylight savings. This has really gone nowhere over decades. It seems like we're going to do it, but then we're not. But I will say that when we spring forward, there is, a loss of 1 hour, and there's consistently a 6% increase in motor vehicle fatalities on the Monday after daylight savings. And so there's like clear human cost to this. Everybody likes a nicer, longer evening. Like, I get it, but it absolutely comes at a cost. Social norms about sleep as a pillar for health, and then kind of more flexible work policies, parental caregiver leave, things that will help individuals manage their day and life better, that will ensure an opportunity for more restful sleep. At the community level, really at the neighborhood. And I was thinking, when in urban planning, there are now kind of health impact assessments when they think about when they're going to build something new or a new community, kind of what kind of impact will this have on health. I think the idea of potentially thinking about a sleep impact assessment and thinking about sleep as a pillar for health. Is there a way to kind of have that be part of the conversation when we build places with, say, green space or near areas that have more light, or, and thinking about what its use is at night and not just about daytime function, I think is really important. And then workforce development. It's interesting that sleep medicine is very under-resourced in the curriculum for professionals. And so one statistic is that there's one sleep medicine physician for every 43,000 patients. And so, that's obviously just when we think about physicians, but in someone that does work, trying to treat people with insomnia behaviorally, there's only a couple clinics in California that take insurance, to do this kind of work. And so, there really is such a need, but such a lack of access. Then at the individual level, I think one of the places where we could really do a better job is in culturally informed interventions. There was recently, so the primary treatment for insomnia, before people take medication, should be cognitive behavioral therapy for insomnia. And there have been kind of a development of digital therapeutics for this, but they're often not culturally informed at all. But there was recently a study that kind of developed one, and it worked as effectively in so it was for Black women, and it worked as effectively as the non-culturally informed one, but the adherence was much higher over time, and so there's much more engagement. And I think that's important. I think it's critical to be able to think through a much more diverse lens. And though our interventions are effective, they're not effective for everybody. And I think a lot of it has to do with the matching or the thought and care that's put into kind of making sure that it is something that an individual can engage in. Similar things have been done for treating obstructive sleep apnea, which I think is really important. So in summary, sleep is a pillar for health. I think I've made that clear, but it's often treated as a privilege rather than a human right. And I think that is the problem. There are clear racial and socioeconomic sleep disparities shaped by upstream factors. I think that the sleep health landscape there's bountiful opportunities for multi-level intervention, but the research needs to be done in a responsible way. I'm constantly trying to learn how to do these things better. And I think in the end, we should be able to make gains and move the needle on how to get more of the populations that need the most sleep sleeping better. And I'm excited to see how this progresses over time. And so with that, I just want to thank all the people that help us do the work and for your attention. And hopefully we have a few minutes for spirited discussion.
Questions.
Thanks.
Thank you very much, Dr. Prather.
Yeah.
Questions? Go ahead and raise your hands, and we can, or put it in the chat. One question, a lot of the studies and disparities you're looking at, they were predominantly 18 years and above in endurance. I'm imagining that these disparities and in school age children, beginning at school age, like that, they're replicated for kids. Are they the same, or are the disparities even more extreme in kids?
Yeah, no, they're definitely there for sure. In adolescence, and I think the more that we begin tracking back to even in infancy, you begin to see these things just because of the way in which sleep is clustered within the family system. And so it's no surprise that you begin to see those things, like whether those disparities are the impetus to drive the health disparities later in life. I don't know, but there's clearly kind of data suggesting that like early. Now that we're even learning that kids can show evidence of kind of early kind of plaques in their arteries and things like that. It's likely that these contribute to it in some way. I don't think we have a causal mechanism for that, but it's certainly plausible.
Got a question, Dr. Guy. Dr. Guy Mignon.
Thank you. So thanks for a fantastic talk. I really appreciate it. I was so excited to see about the sleep. That's why I was like the only person chatting in there. And unfortunately, I rolled in late, but I was like, oh my God, he's talking about sleep disorders, because it's perfect and it's connected to so many chronic diseases. One of the things that I was thinking about actually is linked to the discussion you were just having, which is not what are the effects in terms of within a given family unit, but I'm thinking over generations, over time. Right. So if you have, like, I'm thinking about like epigenetic imprinting, I'm thinking about, right, bro.
Generational trauma. Yeah.
Exactly. Because, oh my God, I'm getting goosebumps. Yes. Because when we're thinking about I focus on Black populations here in Richmond, Virginia, the capital of the Confederacy. And so when you're thinking about sort of the lived experiences of Black people and other racialized groups or marginalized and minoritized groups, we have to think about not just what it's doing over one generation or two generations, but several down the line, especially when we think about poverty and the context in which these sleep disorders occur, right? And so I'm just wondering if you know anything, or if there's any literature out there that's looking at, probably not, that examines sort of the impact over multiple generations? Probably not. I'm
Probably,
keeping answering the question.
yeah. I mean, I
In
certainly.
terms of chronic diseases and things like of that nature, right?
Yeah. I mean, like there are, a couple of cohorts where they are following people across various generations to understand this. I mean, mostly, and it's mostly been around this, like, uh, prenatal stress exposure and epigenetic embedding of disease. But I mean, I absolutely, like any other chronic illness, like the language and the way in which people interact with the medical system, and the way in which people, communities kind of deal with these things, and even the way that people talk about sleep. It's really interesting. Like I mentioned my postdoc at the time, Lauren Whitehurst, she's at the University of Kentucky and is like does a lot of work in like Appalachia around sleep, and just the way that she talks about like how just the language about how people talk about their sleep, it just varies in a way that I honestly just didn't appreciate. Like delving into this, I'm like, wow, like I'm not even sure we're doing this right, like right now. You know what I mean? And it's been humbling for me to like try to just take a step back and be like, oh, are we even using the right words?
That's right.
And
Right.
there's so much work to do, but it's, go ahead.
I have one more question for you. I'm sorry, and I just want to ask this because I want to give other people time. But I lost my train of thought. Oh, the broader. So you were doing a lot of work at the individual or sort of interpersonal, individual level sort of experiences of discrimination. But I'm thinking about the broader political context and climate, which is inherently anti-other, right? Sort of examining how that could potentially contribute to hypervigilance and sleep disorders. I say this, though I shouldn't say it because I'm recorded, but I say this because I started having massive nightmares after the last administration in the US. And so I do wonder, when you have sort of this inherent anti-LGBTQ, anti-Black, anti-whatever, othering in society, within the broader systems and structures that you depend upon for your livelihood, how is that actually sort of affecting sleep disorders and things of that nature?
Oh my God. I mean, gosh, like like I just, even you talking about it, like I had like a collective trauma response, right? Like it's like, and I mean, for being someone that like runs an insomnia clinic, I mean, like we do notice like upticks, right? when things happen. And that's not even getting into this like othering perspective. This is like in the population level, but like, yeah, absolutely. I mean,
did you watch the news yesterday? Oh, sorry.
Yeah,
okay,
yeah.
now are at risk.
Well, I mean, it really kind of speaks to, in like from a research perspective, how important like cohort effects are, right? And like understanding what's happening at the time in which those people are followed, and if you just kind of if you're just kind of resampling like what that means, and we like just in this with respect to like the project that I described, this kind of like experimental discrimination project, which was like very hard to talk about and do, and I mean during the like when the Black Lives Matters movement like got really big, we shut down the project, and we were like, I don't know if we should be doing this, and like maybe we should just give the money back. And it was like, because it was like something, we were changing, like things were changing in the world in a way that it like really made us like think about how we do research responsibly, and
is it ethical to amplify
yeah, I mean, it
stress
was
on a background that may be extremely
oh my God.
high? Yeah, I mean
That's right.
Those are
Yeah,
good things
absolutely.
to think of.
And I mean, and like, should I be the person doing this anyway? Like, it was like a whole, like all of these like existential angst around like doing this work. And I mean,
good. And you're the right
I
person.
know, like,
You're the right person to do the work.
That means you are the
that
right person. Yeah, I agree.
Right? If you have
Well,
that
thank
angst, you're the right person.
Well, thank you, Aric. Thank you, Dr. Prather, Aric. This is terrific. It's fantastic to have you as a resource for the network. We will keep in touch, and for everyone who, if you know folks who would like to take advantage of this session, we will have in a couple of weeks we'll have, or often less than that, we'll have this recording up on the our YouTube channel, and it'll be accessible through links on the Health Equity Action Network website as well. So again, thank you for Dr. Prather, and we'll stay in touch.
Yeah, thank you guys. Such an important work you guys are doing. Thank you so much for having me.
Thanks everyone.